towards the end of March. Got the date? March 24th. We haven't got a venue for that or anything yet. We responded to the feedback that we received from our first public board meeting, so hopefully those that attended the last one will hopefully noticed we've tried to make some changes for this one, because we are learning as we go along as well. One of the areas that we received feedback on was the opportunity to ask questions. We did ask anybody who wanted to ask a question that was relevant to the agenda to submit it before today. This is linked to my insecurities, not for anything else. We haven't received any questions, but are the board happy if we ask the public if they've got anything they want to raise on that's relevant to the agenda? So, thank you for coming. It's great to see everybody. Does anybody have a question for us that's relevant to the agenda? We're going to stick around for a little while afterwards, so if you'd like to come and talk to any, well, some of us will be on a one-to-one. We're very happy to do that.
Any other question?
Jackie Cairns from the CCG. It was just on your agenda you alluded to looking at the walk-in centres, but it hasn't actually been mentioned today, and I wondered how that work was progressing, who you were linking with, because obviously we are very keen to link with you on that work.
Sorry, Jackie, I'm completely confused. I didn't see that. What paper was it on, Craig?
The legacy.
On a legacy document. Okay. Oh, agree. Oh, continue. Oh, okay. Okay. Well, yes, this is really important because I think we need to see what's happening with out of hours. And as an update for board members, the out of hours tender is stalled at the moment because one of the previous providers actually seeking legal advice about the awarding of the tender. So I think it's a waiting game, to be quite honest, Jackie, in terms of waiting to see what happens with that. And I think the board at the moment hasn't got a particular view about what we're going to do. Is that fair to say from the staff side as well?
Yeah.
Sorry, it was more the walk-in centre element of it. It does appear on commissioning intentions for next year for both CCGs. It has come to the end of its contractual period, so we have no choice. We've rolled it over for 12 months in order that we can do a review to understand exactly what we want from walk-in centres. Therefore, we would be really keen to work with them on that.
You know, that's the fact that we don't do consultation, whatever. It'll be built on the 1, 2, 3,
Yes.
the Ofsted stuff. So if we're gathering the evidence that there are issues with walk-in centres, in terms of this or whatever, without a doubt, I mean, you know, that's the arrangement that we've set up with relationships with all our partners. If we hear one thing, we'll give you a call anyway. And if there's mounting evidence, we may actually look at it from a different perspective that would involve you. Is that okay?
You had the discussion about the Better Care Fund. What gaps in provision between health and social care are you aware of at the present time?
Massive question. I'm sorry, I don't know, couldn't answer that question just now. Any board members able to answer that one? Craig? Sorry.
I think from a community perspective, there's quite often concerns about discharge, particularly in relation to older people. I'm looking at Alistair in relation to mental health as well, possibly. I mean, historically that's been an issue. and whether it's become worse with what's being called winter pressures, I don't know. But we've seen it from both sides, from there not being enough facilities in the community to support people, but equally people staying longer in hospital. I call them delayed discharges, but staying longer in hospital because there aren't the proper facilities in the community. I haven't got evidence of the extent of this in Newcastle, but I know if you go out and talk to a number of different groups of people, that can often be an issue.
It's also a question of completely different cultures, not being able to communicate with each other. For instance, sharing of patient information, that sort of thing. It's like two services existing in parallel universes, and to better use the resources we've got that are extremely finite, the two sides actually do need to talk to each other and find out how to make a more intelligent service work together.
Well, forgive me, you're speaking like bureaucrats. I'm just asking you, what experiences have you got, for example, from people being discharged from hospital about the problems they face?
Well, just picking up from Sally's point, in mental health, what we've seen is a lot of people treated for immediate acute mental health problems, and those problems managed in a medical fashion. But a lot of the causes of those mental health problems, or the things that have triggered episodes, have been wider socioeconomic issues, etc., which require maybe not intensive, but some sort of social work input or social care input, but that are deemed not to be sufficiently medically unwell to trigger an entitlement. So people are left to slowly decline to a point at which, yes, their needs have ramped up again, and they incur heavy secondary care health costs. But there's nothing keeping them, there's insufficient stuff just out there in the social care or in the wider social field even, just to keep people ticking along. Just the stuff that is, it's not so much preventative, it's maintenance, it's the stuff that maintains people's well-being. So we'll see people with mental health problems discharged from hospital and not really getting social care, because at the point of discharge they're expected to be able to manage all of their day-to-day life. And that's an unreal expectation. And it's not, I'm not saying they need a heavy input, but they need just something to make life a bit easier, to keep it ticking over. Not doesn't have to be anything intensive or by a very costly workforce, but just enough to keep people from becoming a bigger burden upon pressurised services. And actually, I shouldn't say the word burden, because nobody's a burden on services. Services are there to meet people's needs. It's to people suffering greater need.
And thank you for that question, actually, because I think it actually raises something for us to think about in terms of what is the real gap. And we've got an opportunity with this integration exercise, if we've got the time.
Why don't you get some real human experiences together?
But there is lots of same reasons the King's Fund. So there are banks, but we just don't happen to have.
The King's Fund is a national organisation with an ACT grant. I'm talking about people here in Newcastle. Get their experiences together.
We don't go and get their experiences.
Yes, you're right, we do need to get those experiences, and what we are going to be doing more and more is when we get an issue raised like this, such as the integration of health and social care and the implications of that, we will be looking at the information which we're gathering from various sources, such as the new free phone number, and also when Julie goes out and about and speaking to people. So we'll look at the information we've actually got at the moment and then potentially frame some engagement activities around those issues. So this is going to be one of those issues.
come across a bit pessimistic, which will not be a surprise to us. No, I think you're absolutely right, Jim, in terms of many of us have been recounting not just anecdotes, but collections of anecdotes, which you get enough by the way of anecdotes becomes data, surprisingly, which is what's the only thing that some people will listen to. But we keep pushing on this. I think there are wider blockages in there. One is a cultural thing, because health tends to be very kind of procedure-based, or it's become more procedure-based, assembly line, process-driven. Social care is more relationship-driven. The big one is that, for as long as I've been doing stuff in mental health, I've always said, it could be great to be more integrated, etc. The big one is health at the moment is not means tested. Social care is. And that's beyond our country. That's a big national issue which needs to be addressed. I fear we'll see a levelling down of standards rather than levelling up, so that we'll end up seeing means testing in health. And I think that'll be a shockingly bad step to take. But that's the major impediment, really. The sources of the funding and how the funding comes about. And sadly, service users and carers and members of the public will come up. We keep recounting our stories against managers who can't see beyond where their budgets come from, and their silos. And those silos can't be reconciled until we look at where the money comes from and how it gets there.
Massive agenda, yeah. Any other questions?
Hi, sorry, it's not a question really, but it's just to point out that I agree with this gentleman here, sorry. I don't know if I need the mic actually. And also to point out, I think what Jim's just said about real experience, I think what we need to do is look beyond the budgets initially. I know that's a really difficult one to say, but we need to look at ways of working, because budgets are so important. We need to look at the plans and what priorities are in there and where the cross-cutting themes are, to be able to identify what we can and can't deliver and look at the quality within that. It's really, really very hard. I mean, there is a siloed working approach, and often data in one organisation isn't the same as data in another, and this is where the information comes in and the technical barriers to actually doing something joined up. So I think probably the approach Jill mentioned about casework or looking at opportunities for projects where you could look at the learning and what's being done in those projects can be, if you like, piggybacked and mirrored in other areas where there's joint work, and particularly around mental health, given that the government have just released a document today about how they want to improve things around mental health and strategies, and I think there's a desperate need for that, and some issues around things like autism, where there are high functioning individuals heavily reliant as adults in mental health services who perhaps if they'd been given earlier intervention at a younger age wouldn't be in the system anymore. So I'm not sure where that would come in, but I just think it needs to be considered in the joint strategic needs.
I think we're getting into areas that is business for the Wellbeing for Life Board, but it's good to hear all of this because we can take it back. So thank you. Any other questions or comments from the floor before I close the meeting?
My worry is that the current sort of top-down reorganisation is not integrating the health service, it's split it up into lots of conflicting and competing factions. And if it's breaking up into all these little sort of islands of people